Cheryl, you can go ahead and kick things off if you're ready.
Hi, Kim, can you hear me?
I sure can. You can go ahead and kick things off if you're ready. I don't have all of my tools available as I'm now sharing my screen. So we're recording, we're live, and we're ready to go.
Perfect, wonderful, thank you. And if you're hearing me doubly, let me know, because it looks like Zoom has finally accepted me in. So I'm not sure what you were able to hear before, but thank you so much, everyone, for your time and your patience today. I truly do appreciate it. And believe me, I do know how challenging your days are. So I truly appreciate you hanging in there with me. And I hope to make the next hour very valuable for you. So thanks again for your time. As Kim mentioned, my name is Cheryl Scalzo, and I'm an account specialist with Real-Time Medical Systems, and super happy to share this with you. Kim, you can go ahead and bring us to the next slide if you'd like, and today we're going to talk about, you can bring us to the next one as well. We'll move along. You don't need to look at my face. But today we're going to talk about infection control, and so much of how technology can play a huge key part of that. It's so significant now when we're talking about that early detection and that reporting and all of those time-saving strategies. So one of the things that we'll look at today, and I always like to try to cover this, is kind of what's new and what we need to know. We'll definitely try to make sure that we recognize the role technology can play in infection prevention and control efforts. We'll learn how to obtain early warning signs of the infectious disease days in advance of potential outbreaks, and that's where our centralized surveillance is going to come into play. And a lot of those time-saving infection prevention and control reporting techniques, as well as we'll understand how to formulate a centralized monitoring system to aid in identifying monitoring effects and trends. Kim, you can go ahead and advance. And throughout today's session, you'll notice that I have a lot of resource links built in throughout the presentation, but also I have a nice resource slide for you at the end. So what's new and preparation and review? I usually go back about 4 or 5 months with infection control, because there does seem to be a lot of things that change that sometimes we're not aware of. We do have a new VIS statement for COVID-19 that came out in October, as well as a new RSV statement that came out in October also. Our influenza VIS for our what you need to know, we were using the same one as last year. Your SNF HAI technical reporting, I wanted to make sure I included that for you. Keep in mind, we know it's been part of our QRPs. We're all certainly aware of that by now, but it's going to have that impact now for your fiscal year of 2026. And that data collection started on October of 2022. So be prepared, for what you're looking at now with those HAIs, because it's going to have that reimbursement impact as well. Infection control deficiencies remain among the top 3, and in a moment, we're going to look at the top 10 deficiencies for the entire year of 2023, and they've not changed that much as it relates to infection control. Additionally, just in case anyone is not aware of some of the resources that we have here in Pennsylvania, we're going to talk about the lowdown. It's a great little magazine kind of that comes out, electronic magazine that comes out, which is super helpful to all of us. So I want to make sure I share that with you. Additionally, your infection control plan outline for long-term care facilities has had some updates. Always make sure you're keeping up to date on your C. difficile resources. We have, again, CMS, we know, has come out with some of that strengthened enhanced enforcement for infection control. And a revised state operations manual. And Kim, you can go ahead. And while Kim does that, I'll also make note to everyone that our Pennsylvania state COVID-19 infection control and outbreak response toolkit for long-term care had some updates right after, I think a day or two after I sent Kim our PowerPoint and we completed it. So make sure you grab onto that. If anyone does not have it, my email address is included on this presentation. And so you just email me and I'm happy to send it to you. But they did change some of the language in some of the areas. They also updated some of the text regarding some of the guidance. As we know, some of the guidance has changed. Some of the language regarding our boosters, and they've amended some of the hyperlinks. So I just wanted to make sure I shared that with you. Interestingly enough, here we are looking at our top 10 frequently cited deficiencies. I updated this just about a month ago, a little over a month ago at the end of December. It's not changed. I did double check to see if there were any updates, and not yet. 884. So let's talk about that for a moment. It's no longer part of our state operations manual. We know that it's not going to continue to be part of the regs, but yet we were continuing to report to NHSN, and I believe we're still doing that till the end of this year. So we still have 884 to worry about. It's still going to be a factor that our surveyors were looking at. And it is still the number one deficient area. But make note of number 3, right? 880. So that is our big bucket for infection prevention and control. We're going to talk about it in a moment. Just kind of keep that in mind. You know, even if you go down to 761 of your label and stored drugs and biologicals, I'm going to tell you that there is infection control as a part of that. 812, which is number 4, your food procurement, storage, preparation, sanitary serving, that all has infection control in it as well. So, you know, we'll kind of hopefully be able to share with you today a little bit of how it all blends throughout the entire facility. And Kim, if you want to go ahead and go to the next slide for me. We'll look next at that lowdown. And so this is what I talked about and mentioned for you a few moments ago. I think it's a great educational resource for us in our long-term care facilities. And these are the things that you want to be able to share with not only all of your facility members, but some of these items you want to be able to post too. You know, one of the things that I was able to, just in having a discussion last week, with someone in a Pennsylvania facility, and I talked about bulletin boards. You know, do you have bulletin boards, you know, a main one near the front of the building that you dedicate to infection control? Do you have a location on each of your nursing units that you dedicate to infection control? Does your environmental department have that? Because our environmental services are huge, a huge part of our infection prevention and control programs, as well as dietary. And really, you need things in your therapy departments, your activities. So everybody needs to have the ability to have the resources and the education that they need related to infection control, and use the resources that Pennsylvania has. We're very fortunate in the state of PA, and I am a Pennsylvania person. I've been licensed now for 36 years in Pennsylvania, and we're very lucky to be able to have a lot of the resources. I know sometimes we don't feel that way, but as we go forward and I talk about Act 52 and what it used to be like years ago, I think you'll see that kind of still stands true today. So go ahead, Kim, if you want to go over to the next slide. And this is where I have shared with you the long-term care facility component annual facility survey. So this came out the beginning of January, and we know that we all are completing this annual survey for NHSN. Hopefully, as infection preventionists and DONs, you're included on being able to complete this. What's interestingly enough here is that they've updated some of the questions and some of the verbiage. And one of the things that they're asking us now is, are we using enhanced barrier precautions as recommended by the CDC? Now, I'm not going to spend a ton of time talking about enhanced barrier precautions, and you can just Google enhanced barrier precautions CDC, and you'll find all of your resources for it. What's significant here as we think about it, and I've been talking about it now for about 2 years or close to 2 years with our enhanced barrier precautions. But interestingly enough, I have a lot of folks say to me, you know what, Cheryl, until CMS tells me it's part of the regulatory requirements, I'm not doing it. And I get that. I do, believe me, I get it. But I think that this is a true indication now that CMS is going to combine with CDC, because if they're asking us if we're doing it, that means it's something that they're going to think about adding now to our surveyor guidance. And I believe we're going to be looking at that. You know, are we using those enhanced barrier precautions? Because the CDC is recommending it as a way for us to prevent the development of healthcare associated or healthcare acquired or nosocomial, whatever you want to call them, infections. And so by doing that, we have to show that we're following that CDC guidance. The CDC has to be one of our main resources that we're using as part of our plan. And so enhanced barrier precautions is the other part of that. They're also going to ask us how we're identifying our multi-drug resistant organisms. Are you screening for them on admissions? What multi-drug resistant organisms are you looking at? And then the question is going to be, what are you doing with the information that you have? And that's with everything in long-term care, right? It's what do we find? What does our surveillance tell us? What are we tracking? What are we trending? And then what are we doing to always give our residents the best optimal outcome that we can give them? And when we're talking about infection control, what are we doing to prevent the spread of infection? And so that's where those enhanced barrier precautions are going to come into play. One of the questions I get with them, and hopefully, despite my technical difficulties today, hopefully Kim will have me back maybe in a couple months and we can talk a little bit more about it. But one of the questions that I often get about enhanced barrier precautions is, where do I even begin? Because what it means is that we're putting our residents on a type of isolation, on a type of precaution related to whether or not they have an indwelling medical device such as catheters, whether or not they have an MDRO, whether or not they have wounds. And the list kind of extends a little bit, but it's not too extensive. But what I say is, look, number one, develop the policies and the procedures for it. Do the education. There's great letters that the CDC provides to share with your residents, your families, and your facility team members. And then just take one area at a time. You know, maybe it's, okay, we're going to start enhanced barrier precautions on our residents that have Foley catheters. You know, whatever it is that you decide to start, take it one step at a time to be able to incorporate it. But I am absolutely recommending that if you're not doing enhanced barrier precautions yet, you should really think about it. You know, probably I'd say by the fall, go ahead and get themselves started. Okay, Kim, thanks so much. I know I went on a little bit about that, but you're welcome to advance. Great. Okay, so HAIs. Right off the bat, I want to make note of what I have on the bottom there, which is the resource link for AHRQ. If you're not familiar with AHRQ, as an infection preventionist or the DON, get yourself familiar with that. It is another great resource that we have, that CMS supports us using that in all of our efforts for infection prevention and control, and antibiotic stewardship as well. So don't miss your opportunities by having that as a great resource. Excuse me. So when we talk about our HAIs, I think it's staggering to look at those statistics, that they account for 1.6 million to 3.8 million infections and over 350,000 deaths annually. You know, they're saying 388, and that's a lot. The cost is also staggering. You know, 38 million to 137 million, which to me is a widespread annually. And then for antimicrobial therapy, 673 million up to 2 billion for our hospitalization. So again, it's staggering. We can see here clearly why now they're looking at our healthcare associated infections and pulling it into that value-based purchasing program as part of our reimbursement. In case you didn't know, but you probably can easily guess, that our catheter-associated urinary tract infections are still common, costly, and potentially life-threatening infections, HAIs, for our residents. And an estimated 7 to 10% of all of our long-term care residents that have catheters, including 12% of all new admissions at the time of transfer from acute facilities and long-term care. There's a lot of residents that don't need our catheters. So get yourself familiar with your regulatory requirements regarding our catheters, and make sure you've done all of your due diligence to try to reduce those catheters in your facility. And go ahead, Kim, if you want to go up to the next slide. Great resource here again with the CDC. I can't stress enough that they're giving us that guidance for prevention of our healthcare associated infections. The reason I like to share all of these is because these are what needs to be part of your plan. We'll talk about the infection control plan in a little bit when we get into Act 52. It's part of our program. The Department of Health may easily reach out to you and say, hey, you know what? Go ahead and send me your infection control plan. I just had someone reach out to me about a week ago and say, Cheryl, geez, our field office asked us for our infection control plan. What does that even mean? So hopefully you all know what that means. Hopefully you all have that in play, but your resources are part of that, and the CDC needs to be that. And as we talk about our healthcare associated infections, this is going to be one of that great resources. Next slide. So with all that we've gone over so far and with where we're going now for the rest of our in-service here, is we're going to talk about where do we begin. And it always has to start with the regulatory requirements. Every one of us are bound by our state operations manual and those regulatory requirements. And we know that we have 881, 882, 883. We talked about 884, which was a reporting requirement, is going away. And then 880 is that big bucket. So we'll look at those a little bit. With that being said, now what do? Well, you're going to take all of those regulatory requirements and you're going to pull them into practical policies and procedures. We'll get into that. We'll look at our surveillance system, and that's really where we're going to talk about our technology today. And again, how what we find, what that data gives us, now do the analysis of it. What is it telling you? And then what are you going to do with what you found? And that's where those provisions for improvement come into play. Go ahead, Kim. So the regulations, I've just kind of listed them there for us of, what we're looking at with these. We're going to dive into a couple of them. The infection preventionists, please note that if you do not have an infection preventionist in the facility, you need to go ahead and get one. I will also let you know that in the state of Pennsylvania, as the director of nursing, you should not be the infection preventionist. It depends on unless you have a very low census. So kind of keep that in mind as well. And your infection preventionist has to be someone that is certified. And the CDC has a really great free educational training program for that infection preventionist certification. So I'm not going to dive into too much of it today, but I did just want to make mention of that. And go ahead, Kim, and you can go on to the next slide, and we'll talk about 880 a little bit. As I mentioned earlier, 880 is really that big bucket. This is where, and by the way, prior to the phase 3 requirements that came into play, we started learning about them in, I think, December of 16, and some of them started in December of 17 or November of 17. But first of all, the numbers changed. And second of all, we only had one regulation for infection control. And that's kind of where 880 developed from. It's that bigger bucket of our prevention efforts, really. And it's giving us that guidance of how we need to make sure we have the systems in place for the prevention, identification, reporting, investigation, and control of infections and communicable diseases of our residents. I think, again, it's significant here, and I always like to pop this out, that it's for all facility staff, direct and indirect care functions, contracted staff, consultants, volunteers. So really, it's letting us know that everyone who is coming into the building is a part of our infection prevention and control efforts and knows what we need to do. I always like to give the example here of our podiatrists. We have requirements that are related to our podiatrists. Have you worked with them about their efforts with infection prevention and control? Are they following hand washing? Are they washing their tools that they're using to cut residents' nails with an approved disinfectant wipe or solution in between every single residence? I guarantee you, if you dive into it a little bit, there's a chance you may find that not everybody is being compliant with that. So while the regulations catch all of these things, our policies and procedures have to follow along with them. And then that's part of that surveillance of what we're doing and monitoring of each and every one of our team members. And that includes those that come in from the outside. And so with our next slide now, we'll kind of look at 881 a little bit. And this is where we're really going to talk now about that antibiotic and laboratory results when available. What are we doing with those? And then those antibiotic requirements. This is where it's significant now in tracking and trending what we're doing with our antibiotic stewardship, and technology, again, is a huge part of that. We're not going to get too deep in the weeds today with antibiotic stewardship. We'll absolutely save that for another one because I love to speak about that as well. But just know that you have to have your policies and procedures that are reflecting all of these regulatory requirements as part of your antibiotic stewardship programs. Make sure that your laboratory integration is part of this, as well as your consultant pharmacist. And then our next slide talks about the critical element pathways. If you've ever joined any one of my webinars before, you know that I'm kind of passionate about these and love to speak of them. This is the best thing that CMS gives us in the relation to giving us kind of that guidance of what exactly are the surveyors looking at. Excuse me, what exactly are the surveyors looking at? How can we interpret those regulations? And what do we need to make sure that we have put into place? It's kind of almost a checklist for us, and it's giving us that kind of crystal ball. So when we look at infection control, I just kind of gave a little bit of a pop out of some of the things we need to make sure that we have in place. But I think what's also significant for us here is I want to point out that when you go into your critical element pathways, there's a lot of them. And you don't want to only grab your infection prevention, control, and immunization. You want to make sure that you're grabbing your urinary tract infections. You want to look at bowel and bladder management. You want to look at ADLs. You want to make sure that you're going into dining services, into the kitchen and food preparation. You also additionally want to make sure that you're looking at your environmental services, and that list kind of goes on and on. So I mentioned before, you know, everybody is going to be part of infection control, and I truly mean that. And as you go through your critical element pathways and share them with each of the disciplines and departments, you'll notice that infection control is really a huge part of so many of them. So don't miss your opportunity there to be able to go ahead and acknowledge, you know, be able to catch all of that and make sure that you have everything in place. And go ahead, Kim, if you wouldn't mind going to the next slide. And so here we are with Act 52 of 2007. So I mentioned earlier, you know, I would talk about this a little bit, and really and truly before Act 52 came, you know, there wasn't quite as much, you know, regulation around infection control, although I think everybody really did a great job. But in Pennsylvania, it kind of gave us a leg up on it. And I will tell you that I was back then what we called infection control nurses when this came out. And it was a lot of work to get it up and running in the facility. It was a lot of work to get used to our PSRS system and make sure that we were doing all of the reportings that we were doing, because don't forget, some of these things we're also reporting to our local our local field offices with some of the infections. So, you know, there was a lot going on at that time, seemingly. And then when our pandemic came, I kind of thought, you know what, Pennsylvania's going to do a little bit better than some of the other states because we already had a leg up on it. We already have additional things already in place. We already have a lot of policies built around the prevention of the spread of infections because of Act 52, and even including to our, you know, antibiotics. So really, we did have a lot of opportunities because of this, and I know probably many of you are kind of rolling your eyes at me right now and saying, "Come on, Cheryl, really?" But honest to goodness, I'm going to tell you, yeah, you know, I've been able to kind of watch, you know, what's evolved in long-term care related to infection control for over 23 years now, and over our field, you know, for over, you know, 36 years. So, you know, it really has come a long way, and I think we still have a little bit to go, but I think we're set up to be able to really manage through a lot of the regulatory requirements. What's significant here with Act 52 that I want you to go ahead and be mindful of when we think about what we have happening, and that's with the infection control plan. You know, you want to be certain you have a multidisciplinary committee in place, and even part of the Act 52 plan is going to list all of that for us. It's going to let us know what are all of those measures that we need to have in place regarding our surveillance, our laboratory processes. How are we detecting and controlling those HAIs? And that's going to include then our MDRO. So so much, again, of what is part of our federal regulatory requirements is going to be part of our Act 52 as well. So I do have great links for you at the end to be able to grab onto this in case you are new to your role and you're not super familiar with all of the requirements for Act 52. You'll be able to go ahead and grab onto that. And just as a reminder, too, with that being said, Act 52 also gives us some additional verbiage requirement in our policies and procedures. Go ahead, Kim, if you want to go to our next slide. Okay. So we're going to pause for a couple of minutes on our policy and procedure considerations. I think the pyramid explains it perfectly. We want to develop those policies, and those policies, we're going to develop them based on the best standards of care and also those regulatory requirements. With that being said, then we also need to go ahead and pull in those procedures as part of our policies, right? We want to make sure that our policy is going to be that statement of fact of what we're doing, and then it has to include the procedure of how we're going to go and do all of that. So just kind of keep that in mind. As you're writing your policies and procedures, the first thing that I can tell everybody is, and even if you've not written them, because there's some great standard policies and procedures out there that we can incorporate, but make sure you read every single word of them. And the reason being is because you have to make sure that they are reasonable for your facility. Are they accurate in everything that you have available to you, everything that you have access, and is your facility team able to go ahead and execute those policies and procedures the way that they are written? If not, that's where we're going to get ourselves into trouble with our Department of Health. And that's not just for infection control. That's going to be for everything. Because remember, right off the bat, your entrance conference form is going to include policies and procedures for infection prevention and control, including influenza, COVID, and pneumococcal. They have to be handed in within the first 4 hours of your field office walking into the facility. So they have your policies and procedures. They know what they're going to say. But if they see any breaches that they think are part of the programs that you should have in place, they're going to look at those policies and procedures. They're going to ask you for them again. And that's where we're going to get ourselves into trouble. So make sure that everything is kind of up to speed, accurate, and also as a reminder, you want to be certain that you are reviewing them at a minimum once a year, and that includes by your administrator, your DON, your infection preventionist, your medical director as well. So be certain that you're including all of that. That then brings us to the guidelines. So our guidelines now, we're looking again at, where are we getting this information from? What are we using to develop these policies and procedures? Well, we've talked about this already. We're going to use the State Operations Manual and the regulatory requirements from CMS. We're going to be able to use those regulatory requirements from Pennsylvania Department of Health and our Act 52. You want to make sure that you also have your policies and procedures in place for your Patient Safety Authority reporting requirements that we have. And how do you get into the system? Who has the access? Who's logging in? All of these things that we're doing need to be part of those policies and procedures. And so those guidelines need to include those resources as well, along with the fact that you want to make sure that you're following your standards of care. And then you have your baselines. And so baselines are, what are you setting it to? Are you tracking, trending, and monitoring your infections so that you're able to reevaluate your nosocomial rate infection along with a breakdown of all of your other infections and establish new baselines every single year? As well as, what are your national baselines? What are your state baselines? And then create your own baselines. Do the same thing for your antibiotic stewardship efforts as well. So there's a lot that goes into our policies and procedures, and they can really make and break us. The other thing that I want to be able to point out here is that part of our requirements, and this came out with the phase 3 requirements, your infection prevention and control policies and procedures need to be in a separate binder of their own, have one on each unit, and then also have one in each department. And when you're doing your annual infection prevention and control plan trainings with your team members and even your survey readiness trainings, make sure that that's part of it, that everybody knows, hey, we have separate binders for our infection prevention and control policies and procedures, and you need to make sure that you know where they are. So make sure that that's something that we're teaching everyone in place as well. Okay, Kim, go ahead. You can actually go through 2 slides. We're going to talk about technology now in our infection prevention and control programs. And this is really questions that I want you to ask yourself. This is kind of a great slide to be able to kind of get your own temperature of what do you have going on now as far as your electronic documentation. First thing and foremost is, does everybody know what we're watching for? Are you using any tools? How are you teaching signs and symptoms of our respiratory infections? I mean, some of us are working through that triple-demic. So does everybody know what we're looking for when we talk about influenza, COVID, RSV, how we're testing for all 3 when we suspect even just one? What are we watching for? You know, what are our signs and symptoms of urinary tract infections that we should be looking for and then documenting? And then does your team have or use any tools such as Interact to guide the team? You know, those are some great tools that are available to us. How are you identifying potential signs and symptoms of infectious processes? Where is it being documented? Again, your policies and procedures need to reflect your surveillance process and meet the requirements. Does your morning meeting include surveillance updates and outcomes? And I certainly hope that it does. Our infection preventionist should be that key person that is discussing signs and symptoms of infections and every resident that has known infections every single morning with our interdisciplinary team. Remember, it's not just nursing that needs to know of our residents that have known infections, and it's not just nursing that needs to know of how we're trying to prevent those infections. Q-shift huddles. I wish we were live because I'd ask everybody right now to raise your hand if you're doing Q-shift huddles. And if you're not, I would encourage you to go ahead and do that. If you don't know what they are, it's where you are gathering your team members. It does not have to be just nursing. You can invite your therapy teams, your activity teams, however you want to be able to communicate, but pull everybody together. It's meant to be quick. It's meant to be 10 minutes maybe, where you're saying, okay, guys, you know what? We have now, we want to be able to go through these residents that have infections. I want to be able to talk about some of their signs and symptoms. Here's some of the additional interventions we're putting in place for them. Oh, and by the way, we're also noting that Cheryl, because she's having some increased confusion with her urinary tract infection, we've added additional interventions to prevent her from having falls. So here's what they are. And even go ahead and use that huddle time to do mini in-services. One of the things that I'm going to tell you, and I learned this from surveyors, they're going to recommend every time that you have C. diff in your facility, you do a training. You want to make sure that every time you have a development of a C. difficile infection in that building, you train your team on the policies and procedures that you have in place for C. difficile. Show that you're monitoring, that they're complying with the policies and procedures. Talk about C. diff, make sure everybody knows what it is. There's great tools in the CDC website to be able to share with your residents and your family members. And then I think the other thing is, how are you finding the data that you need in your electronic medical record? Sometimes that's a hidden barrier that we don't realize. Our team members need to know how to work our electronic medical record. It can't always just be, oh, I go in and I type a note and that's all I need to know. You know, are we setting up our dashboards? Do we know how to look at trends for our vital signs? How do we read the documentation? And that's where technology can pull a lot of that information out for us as well. And then are we presenting our outcomes, including our healthcare associated infection rates, to the QAPI committee? And that's part of our requirements. Go ahead, Kim, and then we'll talk a little bit about technology today and infection prevention and control. I like this slide because I think that it kind of pulls together really what we just talked about in our last slide of those questions that you want to ask yourself. And if you find that there was any of those questions where you really don't know the answer, or you think, you know what, we're really weak on that, this is going to help you. So we're going to establish that a consistent and complete data collection process. So again, that's where our IP is really going to come into play there. What is our data summary? How do we facilitate that analysis and calculations of our surveillance rates? Are we using any centralized surveillance in our electronic medical record or with the technology to capture all of that information? How do we identify and isolate our infection trends? How can we easily demonstrate through the use of charts and graphs their types of infections and the location of infections? Remember, we have to map our infections, and we'll talk about that a little bit in more detail. And then are we monitoring the required components of our antibiotic stewardship programs? Next slide. I also wanted to make sure that I pointed out for you as we talk about those infections that we have in the facility. The other piece is you need to know what you're bringing in to the facility. And so are you doing any type of an infection prevention and control admission screening before you bring folks in? Remember, NHSN is now with that facility annual survey. They're asking the question, are you asking about known MDROs on your potential admissions before they come into the building? And so Pennsylvania has helped us out here, and they've given us a great form of that screening checklist that we can go ahead and use. Share this with your case managers. And I know sometimes, we feel like, well, the hospital is going to send them no matter what. That's okay. It's okay if we're going to get our residents with C. difficile infection. It's okay if we're going to take residents with influenza. But the trick is knowing ahead of time that we have these residents that are coming in with their community-acquired infections, and then that we're putting everything into place that we can and need to prevent the spread of that infection. Go ahead, Kim, to the next slide. And so I mentioned earlier some of those pathways and Interact. If you're not familiar with it, it's free for you to go to Interact, set up your own little account, and you can have some of these tools that really provide great little pathways. It's great when you want to do just mini educational series with your team members, kind of bringing us back to the basics of how we're identifying some of those infections. The other piece, though, I think that's significant is how are they reporting them back to the unit managers, to the nursing supervisors and our infection preventionists? How does all of that communication work? And do they understand antibiotic stewardship? Next slide. This is your clinical pathway implementation. So these are the Interact tools that you can go ahead and grab onto to support your efforts in identifying risk and change of condition. What is your standard evaluation tool that you're using across all of the care lines? You can bring this into your documentation, your medication reconciliation process, care planning, advanced care planning, et cetera. But just a great tool to be able to share with you all that I wanted to be able to capture. And go ahead, Kim, to the next slide, and we'll kind of dive in now a little bit in to surveillance. So what is it? It's everybody's has their own little different version, I think, of what surveillance is, and it really can be a broad term. But I think what's significant is remembering that it's ongoing, it's systematic. Then there has to be that analysis, that interpretation, and the dissemination of data. Because it's great if we have a wonderful surveillance system in place and we know how to use our technology to be able to do that. But if we don't do anything with it, if we don't share that information, we're going to get ourselves into a whole heap of trouble here. It is the core activity of infection prevention and control. And then we also are looking at that comprehensive surveillance. So that's where we're really going to now make sure that we're breaking that apart and we're looking at each and every resident. We're taking that entire population into consideration. And we're really going to look at the time and the resources that are required and the analyzation of that infection data and the implementation of prevention activities. And if Kim moves to, you can go to the next two slides, Kim, actually, and we'll talk a little bit about centralized surveillance. And so this is where now you have kind of that automated selection that you're able to make through your technology where you can go ahead and identify those signs and symptoms of infections. Something is helping you now do that mapping and that locating of your infections. Remember that is part of our requirements. Our surveyors can't tell us what our map has to look like, but they can tell us that you have to have a map that mirrors each of your hallways or your units where you're identifying room by room, bed by bed, those infections that are developing in your facility. You should be including the date on those. You should be including maybe your resident initials, what is the type of infection, and any laboratory results, if applicable, for that type of infection. That's how you want to look for your trends. That's how you want to look for, oh, wait a minute, I have 3 urinary tract infections, all with E. coli in a cluster in one hallway. Well, guess what? 3 in a hallway is going to be considered an outbreak. So now that's going to be reportable for you in the state of Pennsylvania. You're also going to be reporting them to your patient safety authority. But the trick is now that you see what happened, what are you going to do with it? You better get down there and you better start doing some hand washing surveys, and you better start monitoring how your team members are washing your hands. And don't forget our agency staff that's coming into the building. Do they know what our expectations are when we talk about our bowel and bladder programs, our incontinency management? Do they know what our expectations are for infection prevention and control? So when you're kind of, trying to rack your brain and figure out why some of these infections are happening, make sure you're capturing the thought of, we might have some team members coming in the building that may not know our policies and procedures. Go ahead, Kim, you can go up to the next slide. I do want to be mindful of everyone's time. Centralized surveillance data monitoring. So this slide really looks like a hot mess, doesn't it? You kind of want to look at it initially and say, what the heck are you showing me? But this is where you want to look for some of those trending patterns and how can I see that daily surveillance. If you go all the way over to just even the top row on the far right, and we look at our oxygen percentages of 93% or less, and I'm able to see that I now have an influx. I now have 12 residents that are struggling with their O2%. Yesterday, I only had 6, and that's a pretty good change from the day prior. So what's going on in my building now? I want to be able to make sure I know who each of these residents are, and do I possibly have, one of our either influenza, RSV, or COVID infections kind of spreading through the facility. So it's a great way with your centralized surveillance to be able to capture trending infectious outbreaks, but get ahead of it and be able to capture the information ahead of time before the resident, before you have a full-blown, kind of little epidemic going on in your facility. Next slide, Kim. And what are we watching for? Well, we're always going to be capturing for us a lot of those things that are going to look for those changes in conditions. Remember, with our elderly population especially, we're not necessarily going to see those overt signs and symptoms of infection. We're going to look for those changes in their weight. We're going to look for changes in their intakes. We're going to look at specific areas such as temperatures, respiratory rates, pulse ox rates like we just discussed, and even our heart rate. So there's a lot of opportunities of what that surveillance can look like and places that we can go ahead and capture that information. Next slide, Kim. And then I think when we talk about those keywords and how we're looking at that data, this is a perfect example of being able to share with you, what are you looking for in your electronic medical record? Again, it's that conversation that we need to have with our team members. What do we want to be documenting? How do we want to make sure that we're capturing these signs and symptoms? Where are you documenting it, et cetera? And then as the IP, how is he or she going through that electronic medical record or using your technology to have this populated for you, to be able to now help you with that surveillance and that data analysis? And so next slide, and we're going to go ahead and you can go 2 slides up, Kim. I really did briefly want to talk about the infection preventionist and antibiotic stewardship. I know I mentioned earlier that we won't get too heavily in antibiotic stewardship today, because really we need to probably tack on another good 45 minutes. And you're all, we're very patient for me for the first 15 minutes anyway. But it's significant here. And again, he or she is going to be that lead role, not only in our infection prevention and control programs, but also for your antibiotic stewardship. So this is just some great bullets as a reminder of what is expected of that person in that role, how we want to make sure that we're supporting them. And if any of you that have joined us today are in that IP role, wanted to make sure that, sharing this with you. If you feel that you are lacking in your antibiotic stewardship, make sure you go to the CDC site, grab onto your core elements document. It's a great little booklet that guides us through those antibiotic stewardship requirements and 881. And next slide. So technology and data analytics with our next slide, Kim, if you have a chance, is going to populate or share with us how we're able to see what some of that surveillance can look like. Hi, Kim, are you still able to hear me? And can you advance to the next slide? There we go. Thanks so much. Thank you. So here's a perfect example of how I want to remind you you're establishing baselines and benchmarks. You have to, at a minimum, once a year, be sure that you are looking at your rate of healthcare associated infections, your rate of each of the infection types, what they look like throughout the facility each month and then throughout the year. And then also you have to have at least one metric in place of how you're measuring your antibiotic usage. Now you take those monthly rates and then you're establishing those annual benchmarks. Do not reach for the stars. You do not have to reach for the stars. You just have to show that you want to improve in what your benchmarks were last year. And you need to make sure that you're doing that at least annually. So don't miss your opportunity to let technology kind of help you with that. Looking at those, what are your data measure sources that you have now? How are you evaluating those outcomes? And with our next slide, we can kind of see now how you're able to do that with those infection types. And I've talked about this. I've talked about the mapping and the locating. We know that this is where we want to be able to get our hands dirty, do that root cause analysis, and then go ahead and be able to put that corrective action in place. How do you now want to be able to put those interventions in place? Maybe you're seeing that on one particular unit, and if this were my example here, I would go down to Unit C, and that's where I'd want to start getting my hands dirty, and I would start doing a lot of those additional surveillance. I would do hand washing monitoring. I would do hand washing tests, really get my hands dirty, and then put those interventions in place, and then now bring that to every unit on the building. But start with where you're seeing that highest prevalence of infections. And again, make sure that you're doing that mapping or that locating of your infection types. And with our next slide, we'll see how you can go ahead and really review that now of your healthcare associated infections versus your community acquired infections. How does that look? What are we bringing into the building? And again, I'm going to look at my overall nosocomial infections or HAIs, and I'm going to see which unit has that highest prevalence. And here too is where I'm going to get my hands dirty and really be able to measure the progress. What are we doing here? And what prevention areas, what prevention measures do we have in place? Keep in mind too that some of your community acquired infections, especially if you have one particular unit that's designated to your newer admissions, sometimes you might see where you have an influx of some of those changes. And go ahead, Kim, to the next slide. This is going to be a quick one. It's just going to be a fast example, and you can hit it 2 more times, Kim. There's a little bit of animation built into that one. This is just a quick example of where you are able to kind of look at some of those trends that are occurring, be able to grab on to those vital signs. And Kim, if you want to tap 2 more times, and it should pop up 2 more boxes for us. There you go. Thank you. Just to be able to capture some of that information and what that looks like. And you can go to the next slide, please. Meeting our requirements with antibiotic stewardship. I wanted to make sure that I reminded everybody of these simple things. You want to make sure that we're talking about those policies and procedures, and we did really talk about that quite a bit. Identify your signs and symptoms ahead of time with your antimicrobial usage. Are you reviewing your 5Ds or your 4 moments? And anybody's able to reach out if you have any questions on what they are. How are you looking at your antibiotic usage? What are those metrics, your antibiograms? And then don't forget your prescribing profiles. And what are prescribing profiles? Well, It means that our infection preventionists and our medical directors are making sure that all of our providers, our prescribing providers, are following our policies and our procedures for our antibiotic stewardship efforts. And I will remind you that at a minimum, once a quarter, you are sharing back to your physicians and your advanced practice clinicians what's called a prescribing profile. You're evaluating them and then showing that you're doing that education. And so, your binders have to be very comprehensive. A lot of it, yes, you can have on your computer. A lot of it we're doing now with our technology. I used to have binder after binder after binder, but now you're able to print a lot of it, but still go ahead and keep your binders for you so that you're able to readily and easily show all of your work and all that you do. Go ahead, Kim, to the next slide. And that's where some of that surveillance is going to work for you. Not only is it helping you to monitor those trends and identify those areas of improvement, but you're going to work through the root cause. And here again, I'm going to ask you to ask yourself, what comprehensive tools are you using? And do you have access now where you can grab onto this information, be able to slice and dice it however you want, to be able to use it as part of your programs and part of your surveillance? Kim, the next slide, please. And that's what we'll talk briefly about your daily preparation. And so I mentioned this before, how the IP is that person who's coming to every morning meeting and really showing how he or she is recognizing the infections. And so let your data analytics support that for you. Let what you are finding in your your electronic medical records be able to capture that. And part of it needs to be those subtle resident specific baseline changes. We talked about that. What are your changes in function? And that's key. And I like to always point that out because that's where our therapy teams can also come into place. And that's where we need to remember to listen to our CNAs. They're the person who spends the majority of the time with our residents. And so when they come out of the room and they say, you know what, Cheryl does not seem right today. Something is going on with Cheryl. I don't know exactly what it is, but something's going on with Cheryl. Take that information and lay hands on those residents, because that's where we want to be able to capture, again, those subtle changes that are happening with our residents. Look for those intake declines. Make sure you know what keywords you want to be looking for in that documentation. Do your risk assessments. And I like to talk about risk with infections all the time, because I guarantee probably the majority of us have been caught where son of a gun didn't a resident start with an infectious process, and then lo and behold, they have a fall. Or lo and behold, we leave them in bed a little bit too long and they might have a little bit of skin breakdown. Or, maybe they were a continent resident who now has a C. difficile infection or a urinary tract infection, and now they have some incontinence. We didn't put enough in place and they have moisture-associated skin damage. All of those things can happen, and of course, and more. So when you have your residents with your known infections, ask yourself the question right now, what are we doing extra to make sure that we do not have any additional decline for the resident in any of those injury areas or any risk area? What's your daily monitoring of your signs and symptoms of infection? Again, do that daily location observation. And the reason I like to say that is because it's great if you're mapping and locating your infections timely and at the time that they're happening. Don't do that as a practice at the end of the month, because that's defeating the purpose of why you're looking at your infections on a map and why you're kind of identifying where they are. You don't want to identify a cluster of infections 30 days after it happened and then put it in as a late report, because you're going to have to put it in as a late report, because if you don't do it, your surveyors are going to see that, when they come back out to the building. So you want to make sure that you're capturing all of this timely, and it has to be daily that you're doing that. And then again, are you meeting those reporting requirements? And then go ahead, Kim, to the next slide. And I think I had some animation built into this one. So hit it 5 times, Kim, and we'll pull them all out. Thank you. So with this one, I like to always end with to make sure our infection prevention and control programs are part of our quality assurance committees and part of QAPI. You must be. We have, our IP gets to have gets to have input on that annual facility IPC risk assessment. looking at those policies and procedures, looking at that surveillance data, including our infection rates and our performance monitoring. And this is where QAPI is a part of this. Our QAPI team has to be included as part of, you know, who's kind of doing that little bit of hand holding with our infection prevention and control committees. They're serving as a resource for developing action plans and correcting IPC incidents, and then also maintaining that written record of decisions. And then our last slide is our additional resources that I have available to each of you. Please feel free to go ahead and grab onto them. I cannot thank you all enough for working through me with my technical difficulties. I'm actually hoping that when I'm able to hang up today, that I'm able to continue working. I know I went a little bit over our 11 o'clock time, but wanted to make sure that I was able to go ahead and help each one of you with that. And thank you so much. And Kim, I don't know if there was any questions that we needed to answer, if you were able to capture those while I was speaking.
Yep, I've got it. I had a couple of folks ask me if I could share the slides via email, and I certainly will do so. I'll send those out right after today's webinar. And I appreciate everyone bearing with us as we work through the technical difficulties. And that's a wrap. Thanks so much, Cheryl. Thank you, everyone, for joining us. We appreciate it.
Thanks so much. And thanks again, Kim. And thank you, everyone. Have a wonderful rest of your day.
You too.